Our last panel for the evening is on chronic musculoskeletal conditions, which of course is a very narrow area, as we all know. It's virtually, very broad. So, but this is sort of in the spirit of primary care. We do a little bit of everything. Dr. Neil Binkley, as I asked to present as the researcher, he's a professor in the Department of Family Medicine Geriatrics and the Associate Director of the Institute on Aging, Co-Director of Osteoporosis Clinical Center and Research Program. And his interest among all of the range of musculoskeletal conditions involves osteoporosis, fragility, fractures, and that part of the spectrum. So he's going to introduce the panel.
Okay, thank you. Well, as you heard, my current job is that I'm a bonehead. And for the last 20 years, I've been involved in attempting to reduce fragility fractures. And as we'll come back to in my presentation, we've dramatically failed. So I think there's plenty of opportunities to discuss. When I was asked to participate in this, and I heard that the topic was common musculoskeletal conditions, my first response is, are you kidding me? Because there's a multitude of things that we could be speaking about, and I am not a rheumatologist. I do not treat rheumatoid arthritis, and in fact, in my prior life, I was a primary care internist about an hour north of here in Marinette, Menominee. And as I said, now I'm a bonehead. But the common musculoskeletal conditions are listed on this slide. You can read those as well as I. I'm not going to read them to you. But basically, I think if all of us are fortunate enough to get to the stage of having gray hair, we are going to have some of these. And in fact, up to half of us, and I would suggest more than that actually. When you take a list this wide, I would say it's virtually all of us are going to have some sort of musculoskeletal disease as we age. It's the most common cause of severe long-term pain and physical disability. Obviously, it affects our quality of life and our psychosocial status. Unsurprisingly, it costs a ton of money, and it takes us away from work and causes loss of wages. I've spoken with Sis on the phone. I have never met her before now, and I'm now going to turn the microphone over to her to present her perspective on her experiences with rheumatoid arthritis. Sis?
Hi, I'm Sis Lauren from Appleton, Wisconsin. And I'd like to thank my doctor, Dr. Carrie Lathrop-Kapal, for the opportunity to tell my story. I had osteoporosis at an early age, and I just had seen my internist for it. And of course, back in the 60s and 70s, there wasn't a lot of medication out there that you can get to help you with the pain and the inflammation. So I stayed with him until I was so bad, my inflammation was so bad, my feet were so bad, that's where my osteo started. And so he finally referred me to my rheumatologist, and I saw her at the age of 55. And when I first saw her, she said to me, "You have more than osteoporosis going on here." So of course she ran a bunch of tests and came back that I have had rheumatoid, and she said, "You've had it for a while." And so, of course, along with the test, she's putting me on more medication. And I'm already on medication since I had asthma as a child, so I've been on asthma meds, and thyroidectomy at 27, so I was on thyroid pills and high blood pressure pills, and I thought, she slapped me with these six new meds that she wanted me to try. And I kept thinking, oh, at least my insurance so far is picking up most of it. The rheumatoid meds, of course, are not generic, so you're paying almost the full price for them. But I thought if this is going to help me to walk, that we would do this. So a couple of them didn't work, and a couple of them did, and after 2 years, she got me kind of settled down, and then at 58, I had my first knee replacement. And then after I had that knee replacement, the other knee went to hell, and then at 59, I had that knee replacement. And so she said to me, your rheumatoid is spreading faster than what we like, so we would like to put you on this drug called Embriel that just came out. And it's an IV medication that I could take there in the office. I could just come in and the nurse would distribute it, and it takes about an hour and a half. And she says I would have to do this monthly. So she just gave me the paper on it, and after I talked to my husband, I thought, I'm paying a lot of money for drugs now. What's this Embriel gonna cost me? So I called my insurance company, and my insurance company said that they would only pay 80% of it, and they looked it up, and it was $4,700, and I would have to pay the other 20%. So I called Embriel, and Embriel said that they have a program out there that would help me pay for part of this. So they said, don't worry about paying this. We will pay what your insurance company will not cover. All I had to pay was a $5 copay. So for 7 months, I was on Orencia, and I only paid my $5 copay. Well, on my next visit to see my doctor, she said, something's wrong with your heart. I can hear some type of a murmur. So then they sent me to a cardiologist, and then they said I had congestive heart failure from the Embriel. So they took me off the Embriel. And so then the cardiologist put me on some new medication and ordered an echo. So then I had my echo. And I come back to see him, and then he says, you have aortic stenosis from your rheumatoid arthritis. And your aortic stenosis is already regurgitating, which means the blood is not flowing through my valve. And I says, are you telling me I need open heart surgery? And he says, yes, you will, but we won't do anything until you have symptoms. So I have no symptoms yet because I think I stay active because I go to the gym every day. So they took me off the Embriel, and they waited till the congestive heart failure cleared up, and then Orencia came out. So between my cardiologist and my rheumatologist said, let's try the Orencia, and I think this is going to help you. So I called Orencia again, and I says, how much is this prescription going to cost me? And she said, it's $4,700. But we will pay what your insurance does not pay. All I have to pay is the $5. And so that went on until I was 65. Well, the day I turned 65, Orencia calls me. And they said they couldn't send me my Orencia through the mail because by this time it went to injection form. So I got 4 needles in the mail monthly, and I could give myself my own injections so I didn't have to pay for the nurses or the IV tubing at the clinic. And they said, because you're 65, Medicare says you cannot give yourself injections at home. You need to go back to the hospital and have it there and not at the doctor's office. So I said, you're telling me now I have to go to the hospital and pay the $4,700. Medicare only approves $2,000 of that. So then my insurance will pay the 20%, and then I have to pay the rest. And they said yes. And then, not realizing it cost $1,934 for the nurse to give me this Orencia and IV tubing. So then the Medicare paid for most of it, and network covered most of it. I only had to pay out of that one $85. But for me to have my IV, they told me I need to go to the chemo room. Well, the chemo room costs $500. As soon as you walk in, they charge me $500. And Medicare will not approve it. And if Medicare doesn't approve it, my insurance doesn't have to pay. So I have to cover the $500 to walk in there for me to have my Orencia every month. So for me to get Orencia is $738 a month that I have to pay. And I have 27 other medications between my cardiologist and my rheumatologist that the cost is just unbelievable. And I just don't think this is right, but Medicare rules, so I guess there's nothing too much we can do about it. Any questions? I'll give you Medicare's number.
Does it work for you, and how does it help or not help your quality
The
of life?
embryo didn't help much. The Orencia does, but it took 7 months before it clicked in. And unfortunately, the rheumatoid is still spreading, and the osteo is getting worse. But without the Orencia, I would be walking with canes if I didn't get it.
So you're basically stuck trying to figure out how to pay for
How to
this
pay for
versus
this.
using canes.
Yeah, because it uses up almost my whole Social Security check.
Any other questions right now? Should we go on? Let's go on. Our next speaker is Dr. Rabago from the University of Wisconsin. He's in the Department of Family Medicine and Community Health, and he's going to be speaking with us about connecting challenges and opportunities in chronic musculoskeletal conditions. David?
Thank you, Neil. Okay, thank you. So yeah, David Hahn alluded to the fact that this is a kind of basket category. David Feldstein earlier said that his group was special because they could do 2. I think we're special because we get to do dozens. Of course, we can't do dozens in 10 minutes at a shot, so we will cone things down a little bit. Thank you very much for inviting me. As Neil said, I'll try to connect a little bit challenges and opportunities in chronic musculoskeletal conditions, and I'll do it in a little bit different way. I work at the Department of Family Medicine and Community Health, and part of my role there is in clinic, and I have a continuity practice, and part is in research. And so I have tried to take some of those challenges that we see in clinical life with patients every day and find strategies to help them in real research contexts. One of those projects, the one I'll describe very briefly today, was funded, I'm still not sure how, by the National Institutes of Health, the Complementary Alternative Medicine Center. There are no disclosures. Okay. These are my people. We have an integrated mighty red team at the Northeast Family Medicine Center in Madison, where I have my continuity practice. Social work staff, addictive, at-risk behaviors folks, nurse practitioner, PA, DO, MD. It's a wonderful group of people. It makes the work I do on both sides, clinic and research, really a joy, and I just love it. So challenges. You know, the main challenge is worth pausing on, even in a time-limited speaking context like this one. The main challenge is that even if we do everything right, even if the patients do everything right, and we see that they do, oftentimes we just can't treat chronic pain completely. Boom, done. In the best case scenario, we still need more therapies. Why is it so much like that in chronic pain? We thought opioids actually were the solution, and we see kind of where that went. Not really all the way. And so we need better therapy. Why are we so behind the 8 ball? One of the reasons is that the context, the paradigm in which we understand and by which we understand chronic pain is changing. It's changing rapidly. Multifactorial pain sources are becoming more clear. Conditions are seen as much more complex than in the past. There's some are less inflammatory, some more degenerative, some less. For example, in low back pain, it's seen multimodal and relatively integrated therapeutic approaches are seen as a go-to model. On the other hand, overuse tendon disease we used to think of as primarily inflammatory, and now that's giving way to a primarily degenerative model. And so some of the old therapies were targeted at things that are seen as not primarily the etiology that is the most driving. Osteoarthropathy or arthritis, likewise, is seen now more as a whole joint disorder, not only as an intra-articular disorder. And so the challenges have really called for new therapies to be developed. The Agency of Healthcare Research and Quality, or AHRQ, Institute of Medicine, NIH, and Department of Defense have all called for new therapies for some of these chronic pain disorders. Mostly Our patients are asking for it. Our patients need better therapy. A brief case report will serve to illustrate some of these things. As a patient in my practice, I've been treating for about a year. Ben is 61, generally well, a little heavy, but not so much. He has progressive knee OA, clinically, radiologically. He has increased pain and overall reduced function every day. He's tried a number of things: weight loss, physical therapy, a couple times, NSAIDs, Synvisc injections, had a steroid injection back in the day. He's seen his orthopod, and he is a candidate for surgery later, but both of them, he and the patient, want to postpone it. What should he do? Anybody have any patients like this? I think so. Anybody this person? Probably. Mainly, what is his concern? He wants to play with his grown kids' kids. He wants to accompany his own grown children to events. That's what bothers him. What should he do? And what should his doctor do? This is the opportunity. It's pretty straightforward. We need some better therapies. We need to be a little adventurous at finding better therapies, and I was fortunate to have a very adventurous and innovative mentor back in the day, and I suspect that he was to many in this room. Jeff Patterson was a physician for over 30 years in the department. He and I got started on a project about 10 years ago on Prolotherapy. It's an innovative regenerative injection therapy for musculoskeletal pain, low back, tendinopathy, arthritis. The idea is that multiple injections are placed at ligament and joint tendon attachments and within joints. Dextrose is an irritant that we think stimulates a local healing response, although frankly, we don't know how. There's evidence that suggests that there's a multifactorial etiology for this. The idea is to reduce pain, disability, and restore overall integrity. It's a good idea. It's what we as physicians do every day. It's an old as time. We just need to get better at it. This is what it looks like when it's being done. Straightforward. If you can do a steroid injection, you can be taught quickly to do a prolotherapy set of injections. We designed a very straightforward clinical trial. With this hypothesis, prolotherapy can safely improve knee pain, stiffness, and function compared to 2 control therapies. Follow me a little bit here on the design. Basically, we just randomized to 3 groups: open label exercise, sham injection saline, real prolotherapy. Blinded every which way till Sunday. It's at least 5 agents blinded. The only ones who knew were the people who gave us the syringes. Here's what happened. Everyone got better. But the answer is, who got better the most? Here's our real group. They got better the most. It's more than 15 points of change on a 0 to 100 scale. It's a good measure. The next question every physician in the room will want to know is, were they statistically different? And were they clinically relevant? The answer is yes to both. At these time points, what happened at 12 weeks, the patients came back and said, "Doc, I felt so much better. I went out and played soccer. I went out dancing. I went out and did whatever I hadn't done in years, and now I feel bad." Luckily, they recovered. Critics, informed people, patients have all said, that's nice at a year. What about over the long term? Is this a lasting thing? There we are at 52 weeks. We pooled these patients that were in the active group with patients from 2 other open label studies and followed them out to 140 weeks. 140 weeks. Steroids last for a few weeks. Synvisc lasts for a few months. What does this last for? There we go. Does it last that long for everybody? Of course not. Nothing is perfect. Nothing's a panacea, but we did okay. 82% of folks reported in continued improvement for that duration. I cannot tell you why natural history took over for 18%, nor can I tell you the phenotype of that group. That's obviously a big next step for our work. This is a rigorous trial. It's terrific in terms of its methodology. It reports a substantial improvement compared to baseline and compared to blinded and active controls. It's safe, well tolerated, high satisfaction. You can imagine people were happy about this. And it compares well to steroids and Synvisc and others. It's pretty good. It's covered by Unity, by prior authorization, I'm very proud to say. It's fantastic, and we're taking good advantage of it, and our patients are the winners, as is our system. But that's the only provider that I know of in Wisconsin. How did our patient do? Really well. He's going to parties, he's playing with his grandkids, he's a pretty happy guy. My main message for this big basket of musculoskeletal chronic pain is that we need to find better therapies, and we need to be adventurous in going out and considering them, researching them, utilizing them, as the evidence suggests is appropriate. There are a host of alternative therapies. This is just one. Other injection therapies, manual therapies, others, all made more accessible and more useful in a multi-care, accessible, team-based approach. Thanks very much. I know I went over time. It's hard to condense this. I'm happy to entertain questions.
All right. Well, I'm impressed that what I've seen of this conference tends to be somewhat evidence-based, and I'm going to stand up here and give you no evidence. I'm also going to share with you a new term that probably none of you have heard of, and that is a bone attack. And why do we need new terminology? Why do we need to make a change? And it's my bias that when we have failed, let's try something different. So I think that this is a huge opportunity, both from a clinical and from a research standpoint. And I don't know that this is the right approach. But I think that what we have historically called osteoporosis and osteoporosis-related fractures, we need to take a different tact. And I think that perhaps partnering with patients and talking about bone attacks is a way to go. And anecdotally, that has resonated with the folks in my practice. Why do I think that this is important? Half of you in this room who are female and a quarter of you in this room who are male are going to sustain a bone attack in your lifetime. And having these bone attacks is not just okay. This is not my aunt, but this is the aunt of a good friend of mine, Aunt Edna. And you can see on the left here, Aunt Edna in her 50s, and you can guess by her clothing that this was probably the late 50s, early 60s. She looked like your average healthy woman, and in fact she was. The woman on the right is the same lady. About 20 years later, you see she's lost lots of height. She's had multiple spine fractures. She's using a cane because she's had one hip fracture, and she fell and sustained a broken hip on the other side and died soon thereafter. So this isn't just okay, and we can and should be doing something about this, and we're not. Why do I say it's not okay? Well, as you can see here, a quarter of folks die, roughly, in the year after they break their hip. And they don't die from the hip fracture, they die from everything else that happens, right? They get in the hospital, they get narcotics, they get decubiti, they get confusion, blah, 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 blah. And that's the downward spiral. But even if you survive, about almost 2/3 require assistance, and about 1/3 are in nursing homes. So in addition to the changes in the quality of life that Aunt Edna had, it either kills us or puts us in the nursing home. And I'm much more willing to talk about nursing homes now as I'm getting older. I recognize it's not a place that I want to be, and most of my patients don't want to be there. And we are failing. These are Medicare data of folks who sustained a hip fracture, and the hip fracture is the sentinel fracture of osteoporosis-related fractures. It's the one that kills us. 10 years ago, we treated 40%. Most recently, we're treating 21%. So in spite of everything that the field that I'm part of has done for the last 2 decades, we're failing. And so given this, it's my bias that it's time to at least try something different. And I think part of the problem is that the medical model has focused on the bones. All we're doing is treating the bones, we're not treating the person. And it's my bias that we need to treat the person and think about exercise, think about falls prevention, optimize nutrition, and oh yeah, maybe we need to talk about medications. And again, not evidence-based, but anecdotally, virtually every patient that I talk to about the osteoporosis medication says, those are bad drugs, I don't want to take them. Well, why is that? And I think some of it is that our news media now likes to report bad news. Virtually every day in clinic, I tell my patients that we need Walter Cronkite back, that we used to get balanced news reporting and now we get entertainment. This is a quote from a friend of mine a number of years ago in his local newspaper. He says that reporting all this stuff strikes distrust in the hearts of folks. It's not good science, doesn't contribute to good care. I just want to share with you an example from about a year or so ago of another thing that happened. All of us saw things like this. These are just cut and pasted from the internet. The FDA says acetaminophen's bad. It can cause your liver to rot. Well, I've known that for the last 30 years. That isn't news. But this was the headlines that got out there. What did the FDA actually say? When you go in and read the report, this is the first line of it. Acetaminophen is commonly used when used according to label directions, has a well-established record of safety and efficacy. So the FDA says this is safe and effective. The headlines say this. This is what we are hearing, not only as physicians, but also as patients. And given all of this that's going on, this is not my idea. I'm not above plagiarizing. This was a bus that was running around Portland, Oregon about 2 decades ago. I think we should be talking about bone attacks. Why do I think that? All of us are familiar with heart attacks, myocardial infarction. And the physicians in the audience know about the metabolic syndrome, the symptom complex of hyperlipidemia, hypertension, diabetes, and obesity. That, when combined with age, family history, and other toxins such as tobacco, causes an MI, a myocardial infarction, or a heart attack that has bad health care and personal consequences. It kills us, it costs money, and it reduces our quality of life. It's my bias that the exact same model holds with age-related fractures. We've suggested that the word be dysmobility syndrome. I don't care what words we use, but I think we should have this syndrome out there that includes what we've called osteoporosis, low bone density. But it also includes sarcopenia, the loss of muscle mass with advancing age. It includes diabetes, and it includes obesity. Obesity used to be thought of as being protective for fracture. More recently, it's been shown that that is not the case, and in fact, obesity actually increases risk for bone attacks. So we've got this syndrome, plus aging, plus family history, plus toxins leads to bone attack, and the same exact adverse consequences. How do we do that as clinicians? I think we don't need to wait. I think we can take it there now. Do your usual osteoporosis evaluation, and then ask really difficult things. How many times have you fallen in the last year? Give us permission to tell you that we've fallen. Did you get hurt? Injurious falls tell us that you're going to fall and break again and get hurt. Then would you stand up from the chair? So if you know, all of us are sitting in chairs in the medical model today. So can you stand up from the chair? And many of my older patients, if you ask them to stand up from a chair, they lean forward, they put their hands on their knees, and they push. And then I say, okay, let me make it a little harder for you. Let me take your hands away. And when you do that, they rock forward and can't stand up. That simple test basically says you're at risk for falling because your legs are too weak to get you around. And in my hands, it's a direct referral to PT. So what are we going to do in addition? I think we need to think about the osteoporosis paradigm of let's do something. Let's exercise. What is the leisure activity that consumes 66% of American leisure time in our older age? Running the remote. We've got really good thumbs. We watch TV. Somehow we need to have a cultural change toward exercise. We need to think about nutrition. I mentioned obesity, it's epidemic, but in our older folks, about 40% are undernourished. And finally, medications. And so I think, you know, this isn't new. We were here 100 years ago when William Osler said, treat the patient, not the disease. And I don't know whether this is a research or a clinical agenda. I think it's both. I don't know the way to bring this to the clinic, but I know it's a terrible problem, and I hope that we can find ways to do better. And I thank you. How much time do we have? Any questions? It's all perfectly clear. It's the end of the day and you want to get out of here?
At what age should primary caregivers start to introduce this test?
Start to what?
Start to conduct the test.
I still didn't understand.
What age should they start to conduct the test? I'm not sure which test.
Start to conduct the test. You're talking about a bone density test? Or
Whatever,
the standing up test?
Whatever you want to call it in your
good.
model.
I got it. Okay. So at what age should primary care providers start thinking about bone attacks? And one of my union cards says I'm a geriatrician. And one of the cardinal tenets of gerontology is that chronologic age is a poor predictor of function. And so I encourage you and the primary care providers not to look simply at chronologic age, but to look at function. All of us have seen 65-year-olds who are functionally 90 and 80-year-olds who are functionally 55. So I resist putting an age on there. I think that when should you start thinking about it? I think it varies. If you've got somebody who's on high-dose prednisone for whatever reason, you probably should start thinking about it in their 40s. Otherwise, I think to start thinking about falls risk and fractures, that goes up rather dramatically after about 65 on average.
This question is for Dr. Rabago. Is that correct?
You got it.
Okay, excellent. So I have rheumatoid arthritis and I've had it since I was 13. I'm curious, I haven't heard about this dextrose injections, and I'm coupling it together because she has a couple questions related to it as well. Can it go into multiple joints, or is it just knee related, and what is roughly the cost of that? You said it's just covered by Unity, I understood that. And then one other question I have is this more for the osteoarthritis, or is it for the autoimmune versions?
Okay, those are all good, very good questions. Thank you. I'll deal with the latter part first. This is a therapy that is covered by Unity for knee OA and tennis elbow, lateral epicondylosis, provided there are certain rather basic prior authorization criteria have been met. We've been very successful, and it's a smooth process. Regarding its indications, it's primarily separate from the prior auth issues and coverage, primarily not done in cases of rheumatoid arthritis. However, clinical practice varies, and in the absence of acute flares or symptomaticity for RA patients, some practitioners do it. I do not. It is considered a multiple joint therapy. Practitioners who do it as a substantive part of their practice use it for the three things that I mentioned primarily: overuse tendinopathy, osteoarthritis of multiple joints, knees among them, but also hips, finger joints elsewhere, and low back pain. Its history, which dates back at least 75 years, is primarily in the treatment of low back dysfunction, low back pain, SI instability, and so on. Data there is a little more equivocal, but as we discussed, the low back chronic pain syndrome and that's non-surgical is very complicated, very nuanced, and it's probably the case that prolotherapy is effective for some specific diagnoses of low back pain and not for others. The generalization of that diagnostic group, I think, has resulted in a watering down of the data. So we need to do better on diagnosis in the testing of this therapy for low back issues.
How often are the injections?
Great question. How often? This varies by by clinician, basically. There's not a society or a overarching governmental body for this. There are 2 or 3 groups that have quite a lot of experience with this. Typically, the injection sets are a month apart for 3 to 5 sessions. However, that varies from less than that to more than that. We're in a group that I'm working with trying to standardize some of those things in an evidence-based manner, and studies like the one I referred to help, but are not sufficient to guide that. It's very much a work in progress, and we're early, obviously, in the research, but it is quite exciting.
Yes. First of all 3 of you gave very good presentations. Ms. Laurel, you talked about your illness and the dilemma of getting coverage from the insurance companies. And being a physician, I encounter that on a regular basis. And for both of you physicians, you give very good talks about both the topics. I am just wondering if at some point our insurance companies or Medicare and Medicaid can look into possibly providing low-cost gym facilities for a lot of patients, because I know they would pay for the physical therapy, but they may not pay for people to get involved with exercise regimens and aqua therapy and underwater aerobics, and all of those can have such good effects for a fraction of a cost. So I'm thinking if somebody would look into doing some researches and see people who were more physically active, what their risk of bone fractures and osteoporosis is, because obviously it will have a good impact on that, compared to what we talk about doing treatment, if we can look into preventative stuff. Healthier patients, healthier bones, healthier joints.
That's a terrific set of comments. I wish that I knew what drives the specifics behind Medicare coverage. I don't. Prolotherapy has been evaluated once by Medicare in 1999 for low back pain. It was denied, I think rightly so. The data were weak. The general issue that you bring up, I think, really speaks to what Brad, did I get Brad right? Brad was talking about. I have to say, a lot of what you said, Brad, resonated quite a bit. We don't do well with preventive coverage. We just don't, and we should do better. All of the things we've heard about today would be much much better managed using a more preventive model. I think that's just correct.
And if I could extend upon that, the classic osteoporosis field has actually left the prevention game. Primary prevention is no longer considered. And in fact, the efforts are being placed on tertiary prevention, the so-called fracture liaison service. So that's where the International Osteoporosis Foundation, the National Bone Health Alliance, all the organizations are just saying, when you've had a patient who has sustained a bone attack, that's the patient that we should be treating. I totally agree with you that prevention makes logical sense, but it's not where the classic osteoporosis field has gone. I think it's a complicated, I think the rationale behind that is very complicated, not the least of which, however, and I'm not a healthcare economist, so I may be speaking above my level here, but it's my understanding that all of us change insurance plans frequently. And if I'm in your insurance plan and I'm 55 years old, I'm probably not going to have a fracture in the next 2 or 3 years. And so by the time I'm having my fractures, I'm no longer in your insurance plan, and therefore you shouldn't bother paying money to prevent my fracture that isn't going to happen while I'm in your plan. I think it's a huge problem. I think to speak to the exercise piece, I think that as sarcopenia enters the more regular vernacular for not only physicians but the lay public, I think we're going to find that exercise is whatever form of exercise is good, and I think we're going to need to find ways to integrate that into our daily activity, not just strengthening but also balance to prevent falls.
Also, if I may, I'm curious, Dr. Binkley, about your personal prescribing habits as it relates to vitamin D supplementation, when you start that, what you do, and what surveillance you might do.
So the question is, when do I start classic osteoporosis medications? Okay. And what do I do? So I think that the classical osteoporosis drugs have been the bisphosphonates, alendronate, et cetera. And as I see the data, it is exceptionally clear that these drugs are effective and safe for 5 years. And when do I start it? I use the fracture risk calculators. The one that has conquered the planet is FRAX. And so I do use the fracture risk calculators, and the National Osteoporosis Foundation says that we should be starting therapy when the risk for major osteoporosis-related fractures is above 20%. That was a cost-benefit analysis, but 20% seems to be a number that's out there worldwide. Recognize as a provider that when FRAX says 20%, that's major fractures, which is just the big four, and the big four, which are hip, spine, wrist, and humerus, account for only about half of osteoporosis-related fractures. So when you calculate a fracture risk of 20% in 10 years, it's actually 40%, roughly. So I initially very strongly encourage people, if they are above 20%, to initiate therapy, and I tell them it's going to be for 3 to 5 years, after which time we're going to take a holiday. The holiday question is much more complicated. I'm happy to talk to you offline, but I think I'd rather not subject the rest of the room to that discussion.
Again, in the interest of time, I want to thank the panel. I think we did a pretty good job of covering the big three here, despite the fact that it seemed like an overwhelming task. So I really appreciate the input of all three of you, and let's give the panel a big hand.